Epistaxis is divided into anterior and posterior bleeds. Anterior bleed occurs due to insult to the Kesselbach plexus, and posterior bleed occurs due to the insult to the deeper structure. It is more commonly seen in older people, hence it has higher risk of aspiration and airway compromise. Most cases of epistaxis are benign and self-limiting, like nose picking and nose blowing. Other causes are trauma to the nose, insertion of foreign bodies, bleeding disorders like immune thrombocytopenia, Waldenstrom macroglobulinemia, juvenile angiofibroma, which is a benign tumor and that is highly vascularized, cocaine use, and hereditary hemorrhagic telangiectasias, granulomatous with polyangiitis. Coming to management, if the patient is hemodynamically stable, then bleeding can be controlled with first aid measures, which involves asking a patient to sit forward with their mouth open. Avoid lying down unless they feel faint. It also reduces the risk of aspirating blood. Pinch the cartilaginous soft areas of the nose firmly for 20 minutes. Then we apply topical antiseptic, which is Nezeptin, which is a combination of chlorhexidine and neomycin. Admission is only done if the patient has comorbidities like coronary artery disease or severe hypertension, or patient is less than 2 years of age, as causes may include hemophilia or leukemia, which is most commonly seen in this age group. If the patient still bleeds after applying 10 to 15 minutes of continuous pressure, then there are further two options, nasal cautery or nasal packing. Cautery is only done when the source of bleeder is visible and cautery is well tolerated. Steps involves asking the patient to blow their nose and remove any visible clots. After that, use the local topical anesthetic spray, for example, cofenilkane, and wait for 3 to 4 minutes. Identify the bleeding point and apply the silver nitrate stick for 3 to 10 seconds until it becomes gray-white. Important thing to learn at this point is we do cautery only at one side first to avoid any nasal septum perforation. Then we dab the area with cotton bud and apply Nezeptin or muciprocin. Nasal packing may be used if the cautery is not viable or the bleeding point cannot be visualized. The first two steps are same. We give topical anesthesia, wait for 3 to 4 minutes, and then pack the nose. Pressure is applied on the cartilaginous areas around the nostril. Then we admit the patient for observation and review. Patients who are hemodynamically unstable or having bleed from an unknown or posterior source, then we admit those patients in the emergency department and provide the first aid measures until the bleeding stops. Epistaxis that has failed all the emergency management may require sphenopalatine artery ligation in the theater, which can be done endoscopically